Hello, Rania. How are you doing?
Hi, thanks for having me. I'm good. Okay. Have I got my slides up? So, hi everyone. My name is Rania. I'm a F2 doctor at the Royal Free Hospital. At the time of the audit, I was an F1 in trauma and orthopedics at the North Middlesex Hospital. And today I'll be presenting our audit that showed our virtual fracture clinic improving the British Orthopedic Association standards for trauma compliance, patient outcomes, and it showed that I delivered cost savings in a lower socio-economic area. Okay, so overview, I'll just be going over why we did the audit, our baseline data, going through the virtual fracture clinic performance, our methods, results after the implementation, and some of the challenges that we identified and our recommendations. So in terms of background, North Middlesex Hospital is part of the North Central London Integrated Care System. It serves a population with very high deprivation and significant language barriers. And the face-to-face fracture clinic faced substantial pressures. The clinics were essentially overcrowded. We were often seeing more than 100 patients per day. We had multiple referral streams, so referrals coming in from ED, urgent elective cases, ward discharges, on-call referrals, and unscheduled walk-ins. So this created a lot of unpredictable demand. There was also difficulty in meeting our BOAST guidelines. So our BOAST guidelines state that we should be seeing patients within the 72 hours of presentation for a soft tissue injury or a bony injury. And you can appreciate that this created a lot of inconsistent care and significant overcrowding. Another thing that we wanted to look at this audit was if patient leaflets were being given to patients, and they were not, and often they were only available in English. So in terms of what are the BOAST guidelines, these are standards of care that patients should expect following an acute soft tissue or bone injury, and these standards can be audited to evaluate the quality of our outpatient fracture clinics. So some of the things we were looking at is making sure patients were seen within the 72 hours of presentation of injury, and making sure our clinics were consultant-led, and also making sure that we were providing the patient leaflets to the patients. Next slide, please. So in 2024, the face-to-face fracture clinic, which is our outpatient orthopedic clinic, it frequently had more than 100 patients being booked per day. On average, that worked out to be 72 patients per working day that we were seeing. And this made flow unpredictable and placed a lot of heavy pressure on both clinical and administrative staff. Our 2024 data shows that we had 29% discharge rate for our new attendances. 9.8% of our new patients that were seen in clinic required surgery. So although on average we were seeing 72 patients per day, if we look on this graph, there were some days where patients were booked where the appointments were exceeding 100 patients per clinic day. So a major finding that we had was 37.4% of patients were breaching the 72-hour target, and 66% of these patients were non-walk-in patients. Average wait for a planned review was 5.5 days, and this reflected capacity problems rather than clinical complexity. Our DNA rates were also a significant issue, so 23.5% DNA rates for our new face-to-face appointments, and then 30% for our follow-ups. And these high DNAs reflect, reduced efficiency and contributed to a lot of wasted clinic capacity. Next slide. So what we proposed to implement was a virtual fracture clinic, and this was designed for acute orthopedic injuries that could be safely managed non-operatively. So what this involves is we have referrals coming in, and a consultant and an A&P will review the images and referral details remotely. Decisions are made within 72 hours and communicated to the patient. So either they have a clear discharge plan, or they're brought back face-to-face for a review. Patient leaflets and exercise sheets were provided at the time of the referral. And our goal with this was to reduce the unnecessary face-to-face attendance, and improve clinic flow. Next slide, please. So the main reasons for introducing a virtual service was that we know this can reduce the demand on secondary face-to-face care, as it's been done before, and these are just some articles stating that. Our main reason for introducing the VFC was to improve our BOAST compliance, reduce our face-to-face clinic congestion, reduce walk-ins, and DNAs. So in terms of the number of patients we will see in our virtual fracture clinic, we've stuck to 25 patients. That's because the BMA advises that around 25 patient contacts per day is a safe limit in primary care, and we've tried to reflect this. This number is conservative, but it reflects our demand. So this was a retrospective closed-loop audit that we did. Our baseline data was from January to December in the year 2024. We introduced the VFC in February, and then we collected data in March. So the VFC ran from February to March, and then we collected the data for the virtual fracture clinic and the face-to-face virtual fracture clinic as well during that time. Data was provided to us by the informatics team at North Middlesex Hospital, and we also used the National Cost Collective Index to calculate the cost avoidance from VFC discharges and the reduced follow-up burden. So in terms of the virtual fracture clinic, this ran over 5.2 weeks, and as you can see, referrals were pretty consistent, averaging 18 per day. So in total, we had 484 referrals over the 5.2 weeks, and 32% of these patients were discharged safely with advice, and 68% of these patients required escalation to a face-to-face review. So discharge rates were higher in the VFC compared to the face-to-face clinic, and this reflects our improved efficiency of patient management. Patients that were seen in the virtual fracture clinic were less likely to require surgery than those that were seen in the face-to-face clinic, and this reflects our improved patient triage. So in terms of comparing our attendances, for our face-to-face clinic before the VFC and after the VFC, you can see that total face-to-face attendances fell by 21%, follow-ups fell by 29%, new patients decreased by 4%, and walk-ins reduced by 8%. And this reduction made the clinic more predictable and less congested. So in our face-to-face clinic before the VFC, the DNA rate was 23.5% for our new patients, and this dropped to 8.3%. And the DNA rate for our follow-ups was 30%, and this decreased to 17.6% post-implementation of the VFC. And this is because patients received clear communication and appropriate appointments. Next slide. So our BOAST compliance improved significantly. So breaches fell from 37.4% to 14.4%, and that's a 61% relative reduction. Average wait for a clinical review reduced to 2 days, so that's an improvement by 3.5 days for our new patients. And this is one of the strongest indicators of improved safety and flow. Next slide. So this slide shows on-the-day waiting times, how long patients waited after arriving for their face-to-face appointment. Waiting times did increase in February 2025 compared to February 2024, and we've proposed 3 key reasons for this. So the complexity of the patients that we were seeing in our face-to-face clinic increased. There were some data discrepancies, so we had some missing data points for our waiting times, and there was a short post-intervention period. So in terms of our projected cost savings, we use the National Cost Collective to work out the cost savings. So direct cost savings from a virtual fracture clinic discharges over the 5.2 weeks was just over £10,000, and we extrapolated this for 252 working days, and the VFC discharges saved us just over £100,000 per year. So we improved patient communication by providing them multilingual leaflets, and we made them available in over 100 languages. We introduced QR codes for easy access, printed copies for those that needed them, and we set out VFC expectations VFC was explained to set out clear expectations, and this greatly supported our diverse patient population. So some of the key challenges, so not all patients were suitable for VFC. We had a few inappropriate referrals, and this initially increased the workload on our on-call team. This was a short VFC study period, and we did acknowledge that we had some missing waiting time data. To overcome some of these challenges while the VFC was running, we introduced posters in the A&E department for quick referencing and decision-making with pathways and clear guidelines. For patients with a language barrier, we booked them for a face-to-face clinic appointment, or we used DA language line while we phoned them. And we also organised multiple drop-in sessions to familiarise the ED staff in terms of the criteria and referral pathways. So in conclusion, our virtual fracture clinic significantly improved our BOAST compliance. It reduced walk-ins and clinic congestion. It reduced DNAs, delivered substantial cost savings, improved efficiency and flow, and it worked effectively in a high deprivation multilingual population. Overall, the VFC is a safe and efficient, sustainable model. Our future recommendations, next slide, sorry. So we would recommend reducing our planned face-to-face clinic volume. We would focus the virtual fracture clinic on new cases only, and we'd provide ongoing staff education for consistent referral pathways, and we hope to perform a longer duration re-audit to assess the long-term performance. Next slide, and then next slide. Thank you. I'm happy to take any questions and feedback.
All right, thanks, Rania. That was super interesting. And yeah, we've got a couple of questions coming in. So we've got a question from Giuseppe. Which online platform did you use for your VFC?
The online platform. So we used we have a care system called CareFlow. I'm not sure if that's answered the question. I was at F1 at the time, so I think the consultants or the A&P who ran at the clinic probably answer that question better. But essentially, patients were referred there. They would have all the information available on their clinic list. So the admin staff would book them onto a clinic, and then they would just go through the histories, the imaging, and then kind of propose a plan. Patients would be called. So it's like a face-to-face clinic, but essentially it's done over the telephone. And then they dictate a letter and essentially send it out to the GP and the patient. I hope that answers the question.
Thanks, Rania. I think Phil might be having a slight technical difficulty, so I'll just say thank you so much. I just haven't. You'll have to remind me perhaps of the question that's just been asked, because we've got a few more in here, but we've only got 1 more minute. So I'm gonna. What was the question? Sorry, that you've just answered, Rania.
About what platform the VFC was running.
We've got a question here. So what do you think contributed to the reduction in surgery when the patient was seen in the virtual fracture clinic versus when it was done face-to-face?
Sure. So when patients came in through A&E...
Can anyone hear me?
Yeah, we can hear you, Phil. So when patients came in through A&E...
Sorry, carry on.
That's fine. We had a set criteria of what patients met the requirement to go into the virtual fracture clinic and what patients met the criteria for the on-call team to be bleeped. For wounds that potentially may require surgery, open wounds or kind of displaced fractures or complex kind of injuries, they were all to be fed through to the on-call team. For stable fractures, injuries that could be managed non-operatively, those were kind of channeled through to the VFC. So seeing that there was less people were requiring surgery, the ones that were seen in the VFC just means that we had improved patient triage at the point of when the patients presented.
Fantastic. Thanks, Rania. And sorry, I just dropped off. Remember that my internet cut out. Excellent. We're out of time for questions now, but hopefully, Rania, you're still around for the rest of the day if people want to message you. So do, as ever with all the speakers, get in touch, keep the conversation going. That's the thing which was amazing last year in person, and we can do our best with it this time online. So people always like to talk about the good work they've done. So thanks again, Rania. That was really interesting.
Thanks for having me. Thanks. Bye.